Okay, class, we are going to talk about the brain. So let's see if we could bring up this PowerPoint here on the brain. So the brain is the largest organ in the body, almost weighs 3 pounds. And the brain is a major organ that's dealing with processing all the sensory information that comes in. It's responsible for storing all the memories, and it's responsible for emotions and all your decision making and all of your behaviors. And if you have an issue right about here in this part of your brain, which is called the frontal lobe, right? You remember the frontal bone. So this is the frontal lobe. And then back here, you've got the occipital lobe. And over here is the cerebellum. All of these lobes in this entire section here is part of the cerebrum. The cerebrum has different lobes, a frontal lobe and a parietal lobe and a temporal lobe and occipital lobe. But this frontal lobe right here is really responsible for a lot of your higher order thinking and a lot of your cognitive function and making responsible decisions. This frontal lobe is responsible for inhibiting a lot of behaviors where let's say a child that may be 4 years old may not have fear of falling down the stairs because that frontal lobe hasn't fully developed yet. It can inhibit the behaviors. A 3-year-old has to wear a diaper. They can't inhibit the ability, they can't inhibit urination, they can't inhibit bowel movements yet. They just go in the diaper, they can't control it. That's due to that frontal lobe development. The heart rate goes so fast, right? The heart rate of children is a lot faster than adults because the frontal lobe can't inhibit that and slow that down. So frontal lobe has a lot to do with responsible decisions, motivation, drive, people that are in their probably late 30s, early 40s and 50s and still living in mommy's and daddy's basement that can't get motivated or get a job and get out of the house and be driven to be to be independent, most likely have some sort of issue in that frontal lobe. Not that they're lazy, it's just that they're acting to the way their brain is coded and the way that it's wired. So these people can be neurologically rehabilitated for sure. So when we look at this slide here, a very important landmark is this central sulcus right here. And when you look at that line, that central sulcus, it's what separates the postcentral gyrus from the precentral gyrus. And we know that the precentral gyrus right here is all about motor, and the postcentral gyrus is all about sensory. So all of your sensory information ends up in the postcentral gyrus, not except, but all of the sensory input, synapses in a part of the brain called the thalamus. All of the sensory input is relayed to the thalamus, and from the thalamus to the postcentral gyrus. That's all the sensory information except for the sense of smell. So the postcentral gyrus is in the parietal lobe, and the precentral gyrus is in the frontal lobe. Precentral gyrus is all motor, 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 and a lot of your motor movements are started in that frontal lobe. That's where the premotor cortex is. Okay, and if you go online and Google homunculus, that's that real interesting picture that represents the entire body in the postcentral and precentral gyrus, where the lips and the face are really large because the fine, controlled, coordinated movement takes up so much brain power. The pinky, the lips, the eyes, these take up a lot of neurons. That fine coordinated movement take up a lot of brain space. But the large muscles like the quads and the glutes for more grotesque movement, not so much. Okay, and then you'll see, pay attention to other parts of the brain. Down at the bottom, you got the medulla, Then higher up is the pons, and just a little higher up than that in this area would be the midbrain. We have the cerebellum, and then we have the cerebrum, which has the occipital lobe and the parietal lobe and the frontal lobe. And then we have, of course, the temporal lobe. That's where your hearing and your taste centers lie, pretty much in this area right here. So I like this picture here because it shows the different parts of the brain. If we go from inferior to superior, we can see we've got the medulla, pons, and then midbrain. Those three sections right there are called the brainstem. And then when we move a little bit, so you've got the medulla is right around here, this section, and that's protected by, let's remember, C1 and the C2 vertebrae. That's really important. So subluxation in the upper cervical area can really distort a lot of function. If there's misalignment or distortion at the atlantoaxial region, then whatever neurologically takes place in that area of the medulla is going to be compromised. Here's the pons, which means bridge, and then we have this midbrain, and we're going to go over each of these sections. Then we have the cerebellum right here. It looks like that leaf. That's the cerebellum. And then the rest of this up in here is the cerebrum, not to be confused with cerebellum. So when you hear the word cerebral or cerebral cortex, that's referring to the cerebrum. And when we talk about cerebellar cortex, that's the cerebellum. Deep in the cerebrum, all the way in here, you'll see we have a diencephalon, and the diencephalon has a lot of thalamus in it. Thalamus, hypothalamus, epithalamus, and the infamous pineal gland. Okay, I like this picture also. I like the cavities that we can see here right in the center. If you look at this, this is where the cerebral spinal fluid travels, in those chambers right in here. They're called ventricles. So we'll talk about the lateral ventricle, which is lateral ventricles 1 and 2. And then we have the third ventricle, and then we have the fourth ventricle here. In order to go from the third ventricle into the fourth ventricle, it's got to go through the cerebral aqueduct. And in order to go from the first and second ventricle into the third, it's got to go through the foramen of Monroe. Okay. There are the same meninges that we had around the spinal cord, we have around the brain, the pia mater, the arachnoid, and the dura mater. We also have bone that protects the brain, just like bone protects the vertebrae. We have fluid that protects the spinal column, cerebral spinal fluid. And we have meninges, the same meninges, pia, arachnoid, and dura mater. Pia mater is closest to the spinal cord, dura mater is closer to the bone, and the arachnoid layer is in between, and the subarachnoid space is where the CSF or cerebral spinal fluid travels. That CSF or cerebral spinal fluid is produced right here in the choroid plexus. These are made of ependymal cells. You remember the ependymal cells, which is one of the not the part of the neuron, they are neuroglial cells or neuroglial cells, okay? Blood flow to the brain comes from the vertebral arteries and the carotid arteries. So we have the vertebral arteries and the carotids. The vertebral artery goes through the transverse foramen of the cervical vertebrae C1 through C6. And they make up the circle of Willis. The circle of Willis is the blood supply to the brain. The brain uses about 20% of the body's oxygen. And if the brain is not getting oxygen for a period of time, then that part of the brain starts to die. It can become ischemic, which is lack of blood flow and lack of oxygen, and those mitochondria of the brain need oxygen to create neurological function. Otherwise, there's going to be permanent damage if you don't have oxygen there, and death of those brain cells. When those brain cells die, they cannot be regenerated. You want blood supply to the brain because not only is oxygen important to get in there, but you need glucose as well. If you're not getting glucose to the brain, there's going to be mental confusion. Excuse me, mental confusion. In fact, when we think about mental confusion, what comes to mind is dementia or Alzheimer's, and a new way of looking at dementia and Alzheimer's. They're actually referring to it as either a mitochondrial dysfunction as well as type 3 diabetes. You've heard of type 1, type 2, but Alzheimer's is now looked at as type 3 diabetes. Here is the blood supply to the brain, that circle of Willis. Here is the actual circle you can see. So we have these vertebral arteries that come up, the right and left. They lead into the basilar artery. And then going to different parts of the cerebrum, to the posterior part, is this posterior cerebral, the middle cerebral, and an anterior cerebral artery. And then there's a posterior communicating and an anterior communicating artery as well. Here's the posterior communicating and anterior communicating. And here's the entrance to the carotids. You can see the internal carotid cut right there. Let's go back here for a second. The BBB, the blood-brain barrier, protects the brain cells from harmful substances and pathogens by serving as a selective barrier to prevent passage of many substances from the blood into the brain. And the BBB can prevent the entry of therapeutic drugs. Injury to the brain may cause a breakdown of the blood-brain barrier, permitting the passage of normally restricted substances into the brain. So the blood-brain barrier is really, really important. The cerebral spinal fluid, CSF, is a liquid that protects the brain and the spinal cord against chemical and physical injuries, and it carries oxygen, glucose, and some other important substances from the blood to the neural tissue. Now, everything that you see blue here, that's part of the ventricles. So here are the lateral ventricles 1 and 2. It then has to flow through the interventricular foramen of Monroe. It then leads into the third ventricle. It goes through the aqueduct of Sylvius, or cerebral aqueduct, and then that will lead into the fourth ventricle. After the fourth ventricle, there's 2 escape routes. One is the lateral aperture, and the other is the median aperture. When it goes down the median aperture, it can also lead down the central canal, which is right in the center of that gray matter. And it goes all the way down to the sacrum, and the sacrum pumps it back up to the brain. So it's sometimes called the craniosacral pump. There's about 3 to 5 ounces of cerebral spinal fluid in circulation. It's a clear liquid, glucose, proteins, ions, and it has mechanical, chemical, and circulation functions. Mechanical protection, it's going to float or buoy the brain in there. For chemical protection, there are ionic concentrations that are needed for our action potentials. And circulation, nutrient waste products. They go to and from the bloodstream through the medium of the CSF. Just another picture of the ventricles. And here we could see the choroid plexus. And you can see that the choroid plexus, let's highlight this here. These are capillaries covered by ependymal cells. Okay, and the choroid plexus is actually located in all of the ventricles. They're constantly producing a little bit of CSF. Here's another view. So in this perspective, we're looking at the left hemisphere and the right cerebral hemisphere. So you can see that there's a lateral ventricle in the right, a lateral ventricle in 2. So that's the 2 lateral ventricles. Here's the third, and here's the fourth. And now you could see why you have the median aperture in the center, and then the lateral apertures on the outside. and then that's your central canal. You can pause this. This is just another more linear illustration showing how CSF is made in the choroid plexus that's found in all of the ventricles, and you can see the flow. If you want to pause it, and you can see how it flows and recirculates through the body. The CSF gets reabsorbed through the arachnoid villi. You can see that cluster of purple grapes that you can see right about here. Here's the arachnoid villus, these purple grapes. And about 20 milliliters an hour is the reabsorption rate, which is the same as the production rate. If that doesn't happen, then you get these conditions where you get water on the brain or hydrocephalus. Then that could be caused by some sort of tumor, some sort of fracture, any type of inflammation or developmental malformation that can take place from traumatic birth. And it just starts to increase the pressure within the brain. And when there's pressure on the brain, it can really do some extreme damage to it. So they'll create a shunt to try and drain the pressure of the CSF from the brain, drain it out of there into the neck or into the chest. So the brain stem is composed of the medulla, the pons, and the midbrain, in that order from inferior to superior. When we look at the medulla is important for several reasons. One of the important reasons is that all the information, whether it's sensory or motor, ascending and descending tracts, travel right through the medulla. So all the information coming up from the feet, up the lumbar spine, thoracic, cervical, have to go through the neck to get into the thalamus, the relay station of sensory input, to the post-central gyrus. So there's very high chances of subluxation in the neck that can create these distorted sensory patterns in the limbs, in the lumbar spine, in the arms, in the legs, just from being subluxated in the cervical region. There are 5 nuclei of 5 cranial nerves. It's 12, 11, 10, 9, and 8, and a little bit of 7. The cardiovascular center is there, and the respiratory center. That's why the C1, C2 area, the atlas axis that protects that medulla oblongata, is tremendous in affecting and influencing blood pressure and respiratory function. This is why after every traumatic birth, these children need to be evaluated by a reputable chiropractor to evaluate the upper cervical spine to make sure that there's no evidence of subluxation that can really hinder and affect the development of the child's cardiovascular and respiratory center. There's information that's going in and out of the cerebellum from the medulla, and then your reflex center for coughing, sneezing, and swallowing are all in the medulla. There's an area within the medulla that is referred to as the decussation and the pyramids. So the pyramids are here, and the decussation, if you look at those pyramids, you'll see that they crisscross right here. They make an X. That X looks like Roman numeral 10, which is deca, so it's a decussation. It's all the corticospinal tracts that are on the right side of the brain crisscross to control the left side of the body. And then the right side of the body is controlled by the left side of the brain. There's just a crisscross of information there. The olive, or olivary nucleus, this is where neurons send input to the cerebellum. The cerebellum is coordinating every single movement that you do. It's kind of like a photocopy center. Everything that the frontal lobe of the brain wants to control movement to, it's going to send a message to the cerebellum, and the cerebellum is going to say, okay, they want to throw the ball. over there, then we're going to have to make some modifications. So it's going to just fine tune and tweak the motor activity. In the dorsal surface of the medulla is the nucleus gracilis and nucleus cuneatus. Now, these parts are part of the posterior columns. Remember the fasciculus gracilis and fasciculus cuneatus? Well, within those regions of the posterior columns is the nucleus cuneatus and the nucleus gracilis. The nucleus gracilis deals with proprioceptive information from the lower extremity, and the fasciculus cuneatus does it from the upper extremity, and they're part of the posterior column. Sensory, 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 proprioceptive input. There are 5 cranial nerves, 8, 9, 10, 11, 12. Make sure you know them by name and Roman numeral as well as their function. When we look at 12, 12 is called a hypoglossal. You can see how Roman numeral 12 is written here on top. There's the 10 plus 2 is 12. It's going to control the muscles of the tongue during speech and swallowing. If someone's had a stroke and they stick their tongue out and the tongue deviates, it can't go straight to the center, but it deviates, there's going to be cranial nerve 12 damage. It should be able to go straight center. We don't want to see any deviation to the right or to the left when they stick out their tongue. Cranial nerve 11. When I hear cranial nerve 11, I'm thinking about the SCM and the trapezius, the sternocleidomastoid and the trapezius muscle. It's typically referred to as the accessory nerve or spinal accessory nerve. So the spinal portion deals with these 2 muscles, SCM and trapezius, whereas the cranial portion deals with the skeletal muscles of the throat and the soft palate. The vagus nerve, remember this one, vagus means vagrant. It wanders to 90% of the human body. And this cranial nerve right here is going to deal with not only 90% of the parasympathetics, but this cranial nerve deals with the stomach, deals with the eyes, deals with the heart, deals with the lungs, deals with the pancreas, the spleen. All of the digestive organs are controlled by the vagal nerve. Vagal nerve, you think parasympathetics, you're also thinking slowing things down for the most part, right? Sympathetic speeds things up. Parasympathetic slows things down, except for digestion. Digestion is the only thing that the parasympathetics actually speed up. When you think parasympathetics, you're thinking craniosacral outflow. And the cranial division is cranial nerve 3, 7, 9, and 10. And then the sacral division is S2, 3, 4. Cranial nerve 3, 7, 9, and 10 is the cranial portion. And then sacral segment 2, 3, and 4. That's the parasympathetics. But the vagal nerve makes up the majority of it, controlling the heart and all the smooth muscle and all of the organs. There's a great illustration of the vagal nerve. I mean, if you look at the importance of that, this is why everyone in their life should always make sure that they have a doctor of chiropractic on their health care team. You have a spine. You need to ensure that that neural integrity, especially in that upper cervical area at C1 and C2, are clear so that the vagal nerve is functioning at 100% or close to it, so that your organs are functioning in a balanced state. Okay? That vagal nerve goes to everything. The tone of that nerve affects the tone of those organs and the health and well-being of you. Okay, so you look at the pancreas, we have to look at diabetes, type 1, type 2, type 3, digestion of proteins, carbs, and fats. You look at the stomach, those sphincters that open and close to allow food in and out of the stomach is controlled by the vagal nerve. The liver and all of its ability to detoxify, the lungs, the heart rate, neurotransmitter function. They're using vagal nerve stimulation to treat depression today. It's spleen, the kidneys. I can't, you know, really enforce that enough. The integrity of the upper cervical spine due to the vagal nerve. Now, what I want to also stress, if you go on to YouTube and you type in Montel Williams, there was a great show called the Montel Williams Show. He's an ex-Marine, and he had MS. And on his show, he had brought in a doctor of chiropractic who was treating him upper cervically, in fact. And if you go Google that, you'll see probably a 6 or 7 minute episode of how his MS was treated and his symptoms were alleviated by a simple procedure of adjusting his upper cervical spine. Make sure you take a look at that. Cranial nerve 9, the glossopharyngeal nerve. Cranial nerve 9, bitter back 9, it goes to the posterior 1/3 of the tongue, whereas cranial nerve 7 deals with sweet, sour, and salty. Sweet, sour, salty 7 to the anterior 2/3. But cranial nerve 9 is the glossopharyngeal nerve. It controls the parotid gland for salivary secretion, where chemical digestion can begin in the mouth. And then it deals with taste to the posterior 1/3 of the tongue. Cranial nerve 8, the cochlear branch and the vestibular branch. So cranial nerve 8 is the vestibulocochlear nerve. Vestibulocochlear. When we look at the word vestibular, from the vestibule of the ear, you remember that from lab. The cochlear looks like the shell of the snail. The cochlea deals with hearing. The vestibule, that deals with the canals of the ear, the anterior canal, posterior canal, and horizontal canal, deals with your sense of balance. Very important. When there's a problem with that, people get vertigo, the feeling of spinning. And there's a condition called BPPV, which is benign paroxysmal positional vertigo. This is when patients talk about, doc, when I turn my head to the right, oh my God, everything spins. When I turn my head to the left and back, I feel like I'm going to throw up. I feel so sick and dizzy. Everything just keeps spinning and spinning and spinning. That's BPPV. Very fixable. It takes about 5 or 6 minutes to take care of this, but people unfortunately don't consider seeing a chiropractor that does functional neurology to treat this condition. And they end up suffering needlessly with this, using motion sickness type of medication that can go on for years and years and years. But something like this is treatable in five minutes or less. Ataxia is a lack of coordination. When you're balanced off, people have what's called an ataxic gait. An ataxic gait is the type of gait that when someone is drunk and they're staggering with their feet wide apart, that's taking a wide-based gait or a wide ataxic gait for stability. The cochlea portion deals with hearing. This is a really important part of the history of my profession. Chiropractic started where the first patient was deaf, and that was in 1895. That's when the first adjustment was delivered to a gentleman named Harvey Lillard, whose hearing was restored by that adjustment. And the second patient was heart disease. So now when you look at the upper cervical spine where the medulla is, you can understand why hearing could be affected due to the vestibulocochlear nerve, and you can understand why heart issues can heal up due to the cardiovascular center being within the medulla oblongata, protected by C1 and C2. There's a great picture just showing the vestibulocochlear nerve. Here's the vestibule. If you look at this section here, those are the canals. You've got fluid that's moving in here. Every time you move your head forward, backward, or turn it side to side, this liquid in here is stimulating little hairs, these little hairs. And those hairs send information into the vestibular nerve, whereas vibration from hearing hits the eardrum, the tympanic membrane, then it hits the malleus, the incus, and then it hits the stapes. and that vibration travels in this direction through the organ of Corti in here, and that vibration hits the cochlear nerve and gives us the feeling of sound. Okay? So vestibulocochlear nerve, vestibular portion for balance, and then the cochlear portion deals with hearing, vestibulocochlear nerve. Pons. As we move up from the medulla, now we hit the pons. You could see the green section above, and this area right here is the pons, or this area here just above the medulla. And there's an area called the pneumotaxic and apnoistic area that works in conjunction with the medulla to help control the breathing. And in the pons, we're going to have cranial nerves 5, 6, and 7. 7 is the facial nerve that controls facial expression, and it also controls the salivary glands, not the parotid gland. The parotid gland is cranial nerve 9, but the other salivary glands are controlled there. And 7 deals with sweet, sour, salty 7, and 7 also closes the eye. Cranial nerve 7 shuts the eye. Cranial nerve 5 deals with the sensory portion to the corneal reflex, right? The corneal reflex, let me get the pen here. The corneal reflex deals with cranial nerve 5 and cranial nerve 7. And cranial nerve 5 is the sensory portion. Cranial nerve 7 is the motor portion. Cranial nerve 5 is the trigeminal nerve that deals with the sensation to the face. V1, V2, V3. V1 is the ophthalmic division. V2 is the maxillary division. V3 is the mandibular division. That deals with sensation to those 3 parts of the face. Remember, the trigeminal nerve is the only cranial nerve that has a dermatome. So the eye is part of V1, the ophthalmic division. So if a bug hits you in the eye as you're jogging or biking, the sensation of that bug hitting the eye makes cranial nerve 7 control the motor to shut the eye to allow you to blink to push that bug out. Okay, and 7 deals with all of your facial expressions, all of the facial muscles. Abducens deals with the lateral rectus. You remember Linder's mnemonic, which was SO4, LR6, all over 3, meaning the superior oblique muscle is controlled by cranial nerve 4, and the lateral rectus muscle is controlled by cranial nerve 6, and all other eye muscles by cranial nerve number 3, the oculomotor. So lateral rectus, which moves the eye laterally, abducts the eye, right? Abducens, abduction. Trigeminal, muscles of mastication. These are your time muscles. Let me get back here. Time muscles, because we have T, I, M, E. The M is for masseter, the T is for temporalis. The I is for internal pterygoid, and the E is for external pterygoid muscles. Those are the chewing muscles, muscles of mastication. But cranial nerve 5, due to V1, V2, and V3, deals with sensation to the face. V1 is the ophthalmic, V2 is the maxillary, V3 is the mandibular branch for pain and temperature to the face. When there is damage to the 5th cranial nerve, you get a condition called trigeminal neuralgia, which is lightning, lancinating, shooting pain to the face. It is a painful, suicidal condition for most that have it. It is the most painful neurological condition on earth. And then when there's damage to cranial nerve 7, you get facial nerve palsy. Half the face is expressionless, doesn't move like the other half. This is a great picture of V1, V2, and V3. So you can see here's one division, here's the second division, and then down to the mandible is the third division. In the midbrain, there's an important region. It has a few different names. One of them is called the tectum, where you have the superior colliculi and inferior colliculi. This region right here is really important. Okay, and I'll show you what their functions are in just a minute. So That's the midbrain, that section right there, just above the pons. And I want you to think about red, black, and twins in the back. Red, black, twins in the back. So for the red, it is the red nucleus, that's the red. The black for substantia nigra. And the twins in the back are going to be the superior and inferior colliculus. That's going to be the twins in the back. Okay, let me show you. Red, black, twins in the back. So the red is for the red nucleus. It's red because it's a rich blood supply, high in iron. If it's high in iron, it can oxidize and rust, which is not good. We don't want oxidation there. And the substantia nigra is produced, the substantia nigra, which is right here, produces dopamine. When there's a dopamine deficiency due to malfunction to that substantia nigra, you get Parkinson's disease. So here's a great picture. I'm just going to circle it right now, right there. So you can see the superior and inferior colliculi, also known as the tectum or the corpora quadrigemina. I like this term better, quadrigemina, because you could see 1, 2, 3, 4. You got the superior and the inferior colliculi. The superior colliculi deals with visual stimulus, like the eyes tracking as you're reading your notes, and then the inferior colliculi coordinates head movement in response to a loud sound. The SO4, here's the superior oblique muscle, deals with the trochlear nerve, and the oculomotor deals with the other 4 eye muscles, right? LR6, SO4, all over 3. Cranial nerve 3 also is responsible for keeping the eyelid open. Cranial nerve 7 shuts the eye. Cranial nerve 3 helps keep the eye open. When the eyelid droops, there's a term for that. That term is called ptosis. The P is silent. Okay, ptosis is when the eye can't raise and it dips. Cranial nerve 2 and 3 work closely together. Cranial nerve 2 and cranial nerve 3. So cranial nerve, when you shine light in the eye, this is called the pupillary light reflex. Cranial nerve 2 is the sensory part. It senses that light has touched the eye. And then cranial nerve 3 is motor. It allows the eyeball to constrict. Okay. The reticular formation helps to regulate muscle tone. It alerts the cortex of sensory signals coming in. Many times I'll look out and see some students dozing off, and once they hear my voice get a little louder, their head bounces up and they jump up, their muscle tone kicks in, and they come back to consciousness. They awake from sleep. You need that, right? I mean, you want to be able to smell smoke if you're sleeping to alert you to wake up if there's a fire, right? So you need that reticular formation. And the reticular formation is just their scattered nuclei through the medulla, through the pons, and the midbrain, all part of that. You've got these nuclei scattered throughout just to keep you alert and awake and aware of your surroundings there. Maintains muscle tone. So you can pause these. This gives you a nice breakdown of the different parts of the brain, the medulla, the pons, and the midbrain, areas that we've already covered. It tells you the cranial nerves that are located there. So in the medulla, let's just remember you have 8 through 12. I'm just writing it this way. You should know it through Roman numeral. And then here you got 5 through 7. And then in the midbrain, you got 3 and 4. So if you look at it in order, right, you got 8, 12, 11, 10, 9, 8, 7, 6, 5, 4, 3, right? And then you got 1 and 2 left, and that's going to come off the cerebrum. Cerebellum, when you think of cerebellum, you think balance and equilibrium, balance and equilibrium. Cerebellum functions in the coordination of your skeletal muscle contraction and in the maintenance of normal muscle tone, posture, and balance. You know, when you get pulled over by the police and they say, close your eyes, touch your finger to your nose, they want to make sure that you have that accuracy. When they go walk heel to toe, heel to toe, heel to toe, they're checking balance and coordination. They want to make sure alcohol hasn't gotten into the brain, into the neural system. You'll notice here, let's get back to that, my bad. When you look here, you have the arbor vitae, it means tree of life, that's the white matter. And then there's the folia, which is the gray matter, like foliage of leaves. Foliage, gray matter, arbor vitae is the white matter. Another picture here, again showing the same thing. You could see the white matter, and you could see the gray matter, folia and arbor vitae. Diencephalon, you got the thalamus and the hypothalamus and the epithalamus. Let's just take a look, see if I can get the pointer here. So here's the diencephalon. It's a region that's got your thalamus and your hypothalamus. When you think thalamus, think sensory, sensory, sensory relay. All the information relays here before it hits the postcentral gyrus, except for the sense of smell. Hypothalamus, which is under it, there's a hypothalamus pituitary connection. And when we get to Bio 204, we'll learn about the hypothalamus pituitary thyroid axis, or the hypothalamus pituitary adrenal axis, or the hypothalamus pituitary gonadal axis. So there's an incredible connection between the hypothalamus and the pituitary. Although it's part of the neural system, there's a strong connection to the endocrine system as well. Hypothalamus is involved with controlling the ANS, the autonomic neural system. It controls your thirst, your hunger, your sex drive, your when you're hungry, when you're full, your body temperature is all hypothalamic function. A lot of eating disorders take place up in the hypothalamus. And then we have the pineal gland, which is part of the epithalamus. And we have some hormones that are produced there, especially melatonin, which is involved with your biological clock. There's your medulla, there's your pons, and we did the midbrain. Now we're in that diencephalon. Here's another view showing right there that kidney bean structure is the thalamus. There are so many different nuclei that are in there, but it's the relay station for all the sensory information that's on its way up to the postcentral gyrus, the parietal lobe of the cortex, except the sense of smell. This just shows you all the different nuclei that are there. Medial geniculate, lateral geniculate, the ventral, there's so many different nuclei that are relaying sensory input from so many different parts of the body. And you can see all the different colors on the left-hand side matching up with the different colors on the right-hand side. Okay. And then there's the hypothalamus, and again, many different nuclei. I won't hold you responsible for the different nuclei, but what I do want you to see is just showing the connection between the hypothalamus and the pituitary. The stalk that connects it is called the infundibulum, and there's an anterior pituitary and posterior pituitary, and this optic chiasm is the crisscross of the optic nerves. And when there are pituitary tumors and that thing gets enlarged, it can put pressure against the optic chiasm or the optic nerve, creating visual disturbances. So the hypothalamus controls the ANS. That's your sympathetics and parasympathetics. It's involved in synthesizing regulatory hormones that go to the anterior pituitary as well as the posterior pituitary. The feelings of rage, aggression, pain, pleasure, arousal, thirst, hunger, satiety, all is controlled by the hypothalamus. Body temperature, sleeping patterns, all hypothalamus. Epithalamus has the pineal, that's going to secrete melatonin, that's going to promote sleepiness, and it's also involved in regulating digestive function. Melatonin is used today to help balance out a lot of IBS-like symptoms. Okay, you can pause here if you want to read up again on the thalamus and hypothalamus and epithalamus function. Okay, let me just see how I'm doing on time on this video here. All right, we're doing good. We're at 45 minutes. We're doing great. Okay, let me just make sure. Yes, we're doing good. Okay. Let's see, where else? Let's take a look at the cerebrum. There's a longitudinal fissure. Longitudinal fissure is going to separate the left hemisphere from the right hemisphere. And when I say separate, they're really connected. They're connected by the corpus callosum. That's white matter that connects the right and left hemispheres together. Women have a much thicker corpus callosum than men do, and they have a much better connection between right and left brains than we do. So if I'm pre-navigation system days, if I needed to get from point A to point B and I was lost, I'd have to turn down the volume, right? I mean, my wife would be able to drive and get us there while doing laundry, cooking, playing the music, doing everything. Just much better connection between the two hemispheres. Each hemisphere is divided into 4 lobes: frontal lobe, parietal lobe, occipital lobe, and temporal lobe. You can see the different colors here. And I'm going to show you the different fissures that separate these lobes. So as I click there, you can see that green one popping up. That's the longitudinal fissure separating left from right hemisphere. Then we have that yellow one popping up. That pre-central and post-central gyrus are separated by the central sulcus. You can see that the pre-central gyrus is part of the frontal lobe, whereas the post-central gyrus is part of the parietal lobe. Then in the green, you can see the occipital lobe, purple temporal lobe, and you can still see the cerebellum there. Okay, let's see where we are here. I like this picture. You can see the central sulcus, pre-central for motor, post-central for sensory information. Parietal lobe is all about knowing where your body is in space and time. When there are issues and the parietal lobe is not functioning as high as it should, these are people that knock things over always with their left hand, their left leg, they're klutzy on the left side, or their perception of their body is off. You know, hey doc, look at my left leg compared to my right. Isn't it thinner? Isn't my right one thicker? Look at my right hand. Isn't it much bigger than my left? Look at my right arm. Doesn't it look distorted compared to the other? That's all parietal lobe issues. Frontal lobe, remember, is your inhibitory center, your cognitive function, your ability to rationalize, make, mature decisions. And when that frontal lobe is not functioning properly, these are people that overreact, hyperreact. They can't inhibit violent behaviors. Anything can set them off. They can't inhibit themselves. Your bedwetters have frontal lobe issues, your high heart rate issues, your anxiety people, all frontal lobe distortion that needs to be balanced out. Let's see what else we have here. Occipital lobe, I'm thinking vision. A lot of visual information comes into the back. And on the temporal lobe is where you have a lot of taste centers, gustatory center and hearing center in that temporal lobe. Great picture showing the two hemispheres. You can see the corpus callosum, those fibers going from one hemisphere into the other. And then there are these projection fibers that are fibers that move within the same hemisphere, connecting one part of the same hemisphere to another part of the same hemisphere. The basal ganglia, what you need to know about the basal ganglia is that it's involved in controlling large automatic movements of your skeletal muscles. You don't think about swinging your arms, they just move. But these things are being overridden today by the overuse of smartphones. The arm should be swinging a particular way, but when people are walking, holding their iPhones or with their hands looking down, they're really messing up their neurology, the basal ganglia. They're messing up the sensory input to both hemispheres of the brain due to the lack of arm swing. And as a result of all the lack of sensory input getting into the brain, there's this digital dementia that's taking place. The limbic system is known as the emotional brain. Intense pleasure and intense pain, everything is felt in the brain, but this is what's going to store your emotions right here. You see terms like the hippocampus, the amygdala, all emotions. You can see the olfactory bulb is there. So this is where the sense of smell goes in. That's why you can smell a nice perfume or a nice cologne and he or she smells great, right? That's the limbic system. Brain injuries, concussions, TBIs, traumatic brain injuries are very, very common with contact sports today. This is something we see in the office regularly and needs to be evaluated. Eye function, eye movement, balance, hearing, cognitive function, performing complex tasks, simple tasks. All of the different centers of the brain can be tested. Contusion is a bruising of the brain. A laceration is a tearing of the brain. And what I want you to look at here is the difference between the blue area and that red area where you have the sensory and motor strip. So the primary sensory area or somatosensory area, which is the post-central gyrus, you can see in the blue is areas 1, 2, 3. The primary visual area, if you go to the green, the occipital lobe, that's number 17. If you look at the primary auditory area, that's number 41 and 42. That's right at that temporal lobe region. And gustatory is 43, just above, just deep to the gustatory area. You can see number 43 right there. Now, these areas have association areas as well, where they're going to relay those centers to other parts of the brain. The motor strip, you can see, is number 4. That's the precentral gyrus. And there's number 44, which is the motor speech area, predominantly on the left hemisphere. When the left part of the brain becomes damaged due to lack of glucose or lack of blood sugar or lack of oxygen to the left side, the damage is on the right side of the body, but speech becomes affected. So when people start mumbling and you can't understand them and they have tingling around the lips and they're losing function on the right side of the body, you're thinking either a TIA or a stroke. The association areas are linked with the primary areas. So although number 17 is the primary visual area that allows you to see, number 18 and 19, let's say 10 years from now, you see Dr. Lindner at the gym or you see me at the store or someplace, you'd be like, okay, I see someone walking towards me. You see me, that's the visual center. Then it relays it to 18 and 19. You can process that, you recognize me, you evaluate, and you go, I know who that is, and you make the connection. So you have these association areas. There is the frontal eye field, which is number 8. So one of the things that we do in the office, we do a lot of checking for saccades and pursuits of the eye. The frontal eye field, right here, we could check for eye movements and the smoothness of eye movements. The frontal lobe is great for assessing saccades, whereas the parietal lobes is great for assessing pursuit movements. Saccade is like your head stays still, you see something from the right side of your eye and your eyes quickly move to it. A pursuit is your eyes gradually pursuing someone, watching them walk across the room. That's a pursuit. Auditory association area, that's Wernicke's area. You can see number 22. That's the area that allows you to hear something and be able to make sense from it, where the words become speech. Okay? Aphasia. This term aphasia is the inability to comprehend words. And there's non-fluent and fluent aphasia. So fluent aphasia is a faulty understanding of the spoken or written word. Non-fluent aphasia is the inability to properly form words. That's like you know what you want to say, but you just can't say it. That's usually damage to the left side of the brain. Broke is area number 44. The fluent aphasia is the faulty understanding of the spoken or written word. And the faulty understanding can be word deafness or word blindness. The inability to understand what someone's saying, or the inability to understand what the writing actually means. Great picture showing left brain and right brain. Left brain is more linear, more language, numbers, math, reasoning, whereas number right is more artistic and creative, more musical awareness, spatial pattern awareness, generating emotion with language, right? There are some people that teach, and when they teach, they are very monotone. When they speak, they are like this. They do not have a well-functioning right brain. You want to be able to, have an affect, to have a different tone to your voice to make it interesting. So difference between right and left brain. Left is where more of the speech center is more dominant in the left side for most people. And we know that the corpus callosum, the connection between left and right side, is far greater in women than in men. So aphasia is going to typically happen from damage to the left side of the brain. I really like this picture here for a few reasons. Number one, I like it because it shows that the right, let's take a look here. If we look at the eye on the right-hand side, you see the blue here? Well, where does that information end up? It's going to end up here on the left side of the brain. But you see this one here, red, that one's going to end up on this side. And then the same thing, the red on this side is going to cross over and end up on the opposite side. And the blue here is going to end up on the same side. And the reason being is when you look at these nerve tracts, the information, here's the nose in the center. So the information that's coming in temporally from the temporal field on the outside comes in and hits the receptors here on the inside of the eye. And it's going to cross over to the opposite side of the brain. The nasal information that comes in nasally is going to cross over and hit the receptors on the outside of the eye, staying on the same side of the brain. And that takes place on both left and right side of the eyes. Both eyes are going to have information that stays on the same side and information that crisscrosses. The information that's received temporally from both eyes, that's going to cross over to the opposite side. Okay? The information that you see nasally stays on the same side of the brain. I also like this because it shows the left hand is controlled by the right brain and the right hand is controlled by the left brain. And you can see the corpus callosum in the center, which is the group of axons connecting both sides of the brain. You should know these waves. EEG stands for electroencephalogram. When we did muscle, there was EMG, electromyography. When we did heart, there was EKG. So there's a difference in these waves. Alpha waves are the normal waves that we should see in a normal resting adult. When you're taking the exam and you're concentrating, we'll probably see some beta waves. If you're frustrated and really frustrated, don't know the answer, maybe we'll see some theta waves. And the delta waves occur in deep sleep and in some pathological states. Again, those are the alpha, beta, theta, and data waves. So alpha waves when someone's awake and resting, beta waves with mental activity and concentration, theta waves with some sort of emotional stress, and delta waves seen with deep sleep. Two other cranial nerves involved, 1 and 2 off the cerebrum. 2 is for vision. Optic nerve is vision. A great picture, as I was showing you before, with that crisscross. This one shows it a little bit different. Let's take a look. If there's information from the temporal field coming in, it hits the receptors here on the inside of the eye where there's rods and cones. But that information, if you follow it, it's going to cross over to the other side of the brain. There's the thalamus, relay for all sensory input except smell, and then it goes to the occipital lobe. And then the nasal information is going to hit the rods and cones of the outside of the eye, and that information stays on the same side of the brain. It hits the thalamus, there's the relay, and then to the visual center, to the occipital lobe once again. Here's your pituitary gland, right in the center. You can understand now if that thing swells, depending on what tract it hits, a person can go blind on the, right side of both eyes, or the left side of both eyes, or one eye completely. The pattern can change depending on what part of those optic nerves at the optic chiasm are being irritated or compressed. Cranial nerve 1, the first nerve that develops the sense of olfaction, the olfactory sense of smell. The odorant comes in through the nose, into the turbinates. You have an inferior, middle, and superior turbinate. These centrifuge, the air and the odorants are going to stick to the mucous membrane. It's going to move in through the cribriform plate where you have all of these holes, and those holes are going to have these bulbs that go through from the olfactory nerve right here, and it's going to lead right into the brain, into the limbic system for the emotional brain. Cranial nerve 1. I like this page here. This goes over the sensory and motor. Sensory is afferent, motor is efferent. You should know the corneal reflex. You should know the direct light reflex and indirect light reflex, or consensual light reflex. And the vestibulo-ocular reflex. This is kind of like the doll reflex. Those dolls, when you put the doll down, the eyes, if you lift your head up, all the way up, if you want to walk, your eyes have to go down. If your eyes go down and you want to walk, your eyes have to look up. If your head turns left and you want to walk straight, your eyes have to turn right. So the eyes and head should always move in opposite directions. And it involves the cranial nerves to move the eye 3, 4, and 6. And the afferent to the eye, the sensory to the eyes, are going to be, could be 5, right? But the rotation of the head is going to come from, look, it's vestibulo-ocular. So what's the vestibular portion? Cranial nerve 8. Those anterior, posterior, and horizontal canals of the ear. The neural system develops somewhere between day 18 and the third week. The neural system comes from ectoderm. So does your digestive system come from ectoderm. It's very important to have good folic acid. We want to make sure that people don't have that mutation or that SNP called MTHFR. Methylene tetrahydrofolate reductase. If people have this, and somewhere between 40 and 70% of the population in America do have some form of this SNP, the single nuclear polymorphism, they have the inability to properly metabolize folic acid. And for people that have this homozygous C677T, or it's called the A1298C. You could be heterozygous or homozygous on these. If you're heterozygous on this one and heterozygous on this one, you should probably take 5-MTHF, 5-methyl tetrahydrofolate, which is the bioavailable form of B9. Or if you're homozygous in one of these, you should probably use that. But everyone should be tested for this. It's a general routine blood test. It only has to be done once in your life. Most of the children that are on the spectrum have MTHFR, infertility, MTHFR, a lot of depression tend to be MTHFR, migraine headaches tend to be MTHFR, people that have trouble losing weight, MTHFR. So really, really good test to get checked. So mom, especially before she gets pregnant, because if she is, she can't take folic acid. If she's MTHFR positive, she needs to use 5-MTHF. Okay, these are the 12 cranial nerves, their name and Roman numeral. You should know them, and you should know their basic functions as well. The mnemonic that we gave for this was on the bottom. It's a little different than the one they gave. I think the one in class I said was O, 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 to touch and feel very good velvet. Ah. Okay. Okay, nothing new here. We've done all of these cranial nerves. You could look at these, but we've covered them. Just a different view of the same cranial nerves. I like this one. You know why I like this 8th cranial nerve picture? I like it because it shows the semicircular canals, the anterior, posterior, and horizontal canal. And you could see the vestibular branch going to that. So when this part is involved, this is going to give you the vertigo. This is when you hear people that have these crystals that gets dislodged in here, and when they like lie in bed and they turn left, everything spins. When there's damage here, this is deafness right here. Okay. Glossopharyngeal. Okay, we did that. There's the vagal nerve, my favorite. Good. Good. Okay, CVA, cerebral vascular accident. This is your stroke, ischemia due to decreased blood flow, or hemorrhagic due to a ruptured vessel. These are the two different types of stroke. It's either a blood clot, which is going to result in ischemia. You're not going to get blood to where that blood vessel is leading to if it's a clotted vessel, or the blood vessel ruptures. Ruptures are very common in people who have high blood pressure, who are smokers, who are on medication, who are deficient in vitamin C, who are on a polypharmacy of medications, soft tissue, genetic conditions. So many different things can affect the integrity of blood vessels where they can actually rupture. If someone is having signs of a stroke and they have, let's say, numbness and tingling to their face, and they have nystagmus, which is this rapid eye movement, and they're slurring their speech, numbness to their face, and they lose function of one of their limbs, and they think, oh my gosh, I'm having a stroke. Most of them will take aspirin, pop aspirin, and think, it's going to thin the blood, and I'm going to be saved. Now, if it's ischemia, it did save their life. But if it was a hemorrhage, it killed the individual, because aspirin thins the blood, and if they're a hemorrhage, you just created more bleeding. So the best thing to do is get them to an emergency room ASAP, let them evaluate what type of stroke it is, then they'll administer TPA, tissue plasminogen activator. It's got to be used within the first few hours to prevent permanent disability. If it's a TIA, this is just a temporary cerebral dysfunction due to a lack of blood flow to the brain for a very, very short period of time. They do get dizzy. They have a little bit of a slurred speech, a little bit of blurred vision there. It doesn't last long, just a few minutes. It passes, and there's no residual. There's no long-term residual effects as a result of that. But it could be an important warning sign for a Doppler ultrasound or an MRA of the blood vessels of the brain. Treatments for this are usually anticoagulants or blood thinners or aspirin, or they drink more red wine, they eat more garlic, they take niacin and fish oils and vitamin E, all thin the blood. I would never do all of those things at one time. But most people take baby aspirins. You can tell who's on them because they get bruising very easily to the back of the hand and back of the forearm. They get all of these black and blues all over because it thins the blood. Alzheimer's disease or dementia, they have the inability to reason. They can They can read. I'm sorry, they have the loss of reasoning, the ability to read, to write, to talk, to eat, to walk. They just they're living in a different time frame. It becomes very, very frustrating for the family members to work with them. It's typically affects a population of over the age of 65. We are seeing it in younger and younger people today due to digital dementia, due to smartphone usage, iPhone usage. The brain is receiving lack of proprioceptive input from the body due to lack of proper sequence of movements. The loss of neurons that release acetylcholine can cause it. It's called type 3 diabetes. It's also a mitochondrial dysfunction. Beneficial effects of estrogen, vitamin E, ginkgo biloba are all being currently researched today. And that's it, folks. That's what we have on the brain.